Today I'm going to be talking very briefly about renal disorders in the elderly. Just because it's such a wide topic, I'm going to try and just give you an overview. I have no conflicts of interest and in compliance with ACGME standards. For commercial support of CME activities, I have no relevant financial um, relationships to disclose. So the learning objectives are very simple, very quick epidemiology of renal disease in the elderly, renal disease and difficulties very specifically to the elderly, and very briefly just to touch on dialysis in the elderly. So when we go into the epidemiology of renal diseases in the elderly, the first question that always comes up is who is the elderly? You have multiple definitions of this with no universal acceptance. You can go with what the World Health Organization says, the American Association of Retired Persons, which in 1958 came up with over the age of 50, which of course, is half the universe right now. And of course, when you're looking at kidney problems, one of the things that one of the key sources we go to is the United States Renal Data System, which looks at over 65 because that's when people are eligible for Medicare. The generally accepted statement would be over the age of 65 in the United States. And this goes back very briefly, just the history, 1936, when Social Security was created. At that point, only 5% of the population was over 65, and the average life expectancy at that time was 5 years if somebody was 65 years, compared to 2011, where if somebody was 65, the expected lifespan beyond that was 20 years. So at that point in 1936, when at the age of 65, people got Social Security benefits. Now, of course, the rules have changed and will keep changing, I think, as people live longer, to keep increasing that age at which benefits will kick in. So what about the absolute number of people who fall into this category of people who are over the age of 65? In 1900, it was just 4%. So it was 3 out of a population of 76 million. In the year 2000, it was 12%, which was 35 out of a population of 280 million. In 2020, it was 71 million, which was close to 20%. So 1 in 5 people in the US are 65 or older. And seeing the trend as way back in 1960, people saw the need to start training medical professionals just in geriatrics because of what's commonly known as the silver tsunami. So now we move on to, okay, that's the gist, that's the need. That's the need for looking at our geriatric population. What about kidney disease specifically? So when we look at acute kidney injury, the definition for that is a decrease in kidney function over a period of hours to days, and it can be measured through various criteria. Since the kidney obviously produces urine output may be one of the very quick measures that can be followed. When we're looking at serum creatinine, which is the easiest measurement since it's done with almost every chemistry, the serum creatinine is it's readily available, and changes can be noticed very quickly because it's a number, so it's an absolute. And in addition, most of the labs in the United States now automatically calculate a glomerular filtration rate, or an estimated GFR, as we call it. So going a little bit specifically, there are different criteria that actually come up with these definitions. So you have different, I would say, communities that have come up with this. So you have the Acute Kidney Injury Network. You have the Rifle criteria, which is risk, injury, failure, loss, and if it progresses to end-stage renal disease. We also have KDIGO, which looks at stage 1, 2, 3, and then the rise in creatinine and decrease in urine output. The primary problem with all of this is, besides the rise in creatinine, what's happening is you have retention of toxins and you have dysregulation of fluid and electrolytes. Those who have acute kidney injury are much more likely to progress to chronic kidney injury, and those with acute kidney injury have an increase in mortality. And these last two statements about the progression to CKD and the increase in mortality is seen across the board in anyone who has AKI. So, whichever criteria you use to come to the conclusion that the person has AKI, the implications of that, the negative implications, are present across the board. What about chronic kidney disease? So once somebody has kidney disease, we look at a period of 3 months and we repeat the creatinine to see whether it's stable. If the creatinine is elevated, so if there is a decrease in glomerular filtration rate over that period of 3 months, we can say, okay, this is chronic because we've seen it on 2 separate test results. And we look then for stability. So you're saying we need 2 tests over a period of time, which is separated by an interval of 3 months, to actually diagnose somebody and then categorize them as CKD. And this, of course, has implications in terms of, not just their health, but also their insurance and their financial viability down the road. This is noticed by, we already mentioned, a serum creatinine over a 3-month period, irrespective of cause. So if somebody is dehydrated and they basically now come back in 3 months and now their creatinine is elevated because they had some other issue, it's still AKI. So this is just a diagnosis based on a lab. It's not telling you what the cause of the problem is. The other thing that we look at besides the serum creatinine and the calculation of the glomerular filtration rate based on that creatinine is the functional abnormality of protein in the urine. And the third thing, so what if there's no elevation of serum creatinine and what if there is no protein in the urine? For example, if somebody has an anatomic problem like autosomal dominant polycystic kidney disease, so you're finding a problem on imaging, we also say obviously that the person has chronic kidney disease because they've had it for a very long time. So those are the different criteria that you put people into the categories of CKD. Specifically going into aging and the kidney. For every decade over the age of 40, the GFR declines by 10 mLs per minute. So that by the time somebody is 70 years old, the kidney function, the GFR, has declined about 30 mLs. So a good rule to kind of remember is at the age of 70, a person usually has 70% or 70 mLs per minute GFR. And this is even if their serum creatinine is in the normal range. So obviously the aging process is compounded by risk factors, which are both hemodynamic and non-hemodynamic in terms of activation of the renin-angiotensin system. And this makes somebody who's older much more susceptible to CKD. Now, what are the strategies to try to retard CKD progression? It has to involve both the traditional and non-traditional risk factors in terms of looking at target goals, and as well as, on the other hand, looking at initiation of renal replacement therapy before the person ends up in CKD5. Now, since transplant is limited, one, because of you have to think about, is the person a surgical candidate? And 2, because it's a limited resource, there is a limitation in transplant. So realistically, your choices when you're talking to patients may be more towards dialysis therapies. So let's just classify CKD for a little bit. This is one of the nice KDIGO tables. And you're looking at the glomerular filtration rate, which is based on the serum creatinine, and it gives you your stages here. The higher the stage, the less the kidney function. This is giving you the estimated GFR here. So these are the different stages, and this is basically where the estimated GFR would be. This is based on just the serum creatinine from blood work that's done. So this is what your lab would be reporting. On the x-axis on this side, what you're seeing is albuminuria. And that, again, it's just a function of how leaky the glomerulus is. It's also a marker of vascular disease. So this is significant in that it's telling you well, does this person now have coronary artery disease as well? So those are the key implications that you're dealing with. And you can see that this is also classified, this is also graded based on the amount of protein there, albumin, urea there is. Once the person reaches, and what, going back to this for a minute, the point of the different colors is basically to just remind people that the closer somebody is to having a lower GFR, the closer they are to starting dialysis. The closer they are, the more likely they are to end up needing dialysis. That would be the more accurate way of putting it. And that's the same thing with the amount of albumin urea. The more albumin, the more protein is lost in the urine, the more damage there is to the glomerulus, the greater the chance that kidney disease will progress. So this is basically just a visual depiction of the risk of progression to CKD5, which would be at that point needing dialysis. Now, switching gears just to go into renal issues that are very specific to the elderly. One of the big ones is measuring renal function, and we'll talk about that in a minute, just because serum creatinine and muscle mass changes. The other specific conditions are urinary retention and obstruction, polypharmacy, frailty is a big one, and compounding mortality. We'll talk about that. And of course, in 2021, what we've seen all of last year, one of the biggest risk factors for mortality with COVID-19 was aging. And then, of course, there's this whole thing of, should we proceed to dialysis? And then there's a very common statement, the family wants everything done. And nobody seems to know at that point whether the patient wanted things done or how to make a decision, how to go ahead as a team in terms of renal replacement therapy. So measuring kidney function, most of the renal measurements are based on molecules. Basically, creatinine is the commonest. And creatinine is produced at a constant rate based on muscle mass. So it's a non-enzymatic dehydration of muscle creatinine. It's freely filtered, it's not reabsorbed, and then it's secreted. So it's relatively steady as long as muscle mass is steady. Now, if somebody starts losing muscle mass and we see an improvement in serum creatinine, and you notice on the lab work that their GFR is now better, it's a tricky situation because the patient obviously is not better. They've just lost muscle mass. So you have to look to other ways to determine what their renal function is. Okay, we don't really use inulin or cystatin C in clinical practice, but those are options that are out there. Now, this is an estimated calculation, and it's based on most of the equations basically are using serum creatinine and age for the GFR. One of the key things that I remind people that the kidney does is renal clearance of enzymes, of hormones, and drugs. Those are the key things, in addition to providing clearance. And this all needs to be adjusted for age. So even if we see that the person has a renal clearance of 80 mLs per minute, would you still give them the full dose of the medication? Because is there something like cellular clearance, which is now much slower in terms of patients who are older? So that's the other thing. And polypharmacy, I think I'm kind of preaching to the choir here because people are very familiar with polypharmacy as patients get older. So this is looking at aging, lifestyle, social factors, and chronic kidney disease. Now you're seeing the various comorbidities, and with the comorbidities, you can see that there would be a whole number of medications. What about the complications? You're seeing that there will be inflammation, hypermetabolic stress, increased energy expenditure in the setting of inflammation. And now in this situation, now you're also dealing obviously on the other side with aging, and which is chronologic and biologic. I'm trying to see if I can actually look at these slides. Okay. And in terms of lifestyle factors, there are things that are modifiable like smoking and diet. At the other hand, there are also the chronologic basics, which is your enzymatic levels, um, social factors, the things that would help with social factors. And when you're dealing with the elderly, specifically sarcopenia in terms of poor muscle mass and exhaustion from physical inactivity. So when we're putting all of this together, and now you're saying, okay, in addition to that, we also have CKD, this is where we usually are with patients. Now, moving along to a very specific condition, which for some reason for the last 2 months, I was on service last month, and for some reason there just seemed to be a lot more urinary tract retention, or urinary tract obstruction. And the condition basically with urinary retention, the problem that we see is there's a problem with it's impaired emptying of the bladder, and there's a large post-void residue. The incidence as far as related to medications is not really clearly known. So even though there is well-studied observational studies about the incidence of acute urinary retention, how much of it is drug-induced? That information is not readily available. Micturition is a complex mechanism, and there are many medications that can interact with the micturition pathway, all of which have different modes of action. So data from observational studies just very superficially suggest up to 10% of these episodes of acute urinary retention may be attributable to medication use. So that then says, well, if you have an older person who has now sudden rise in creatinine, one of the first things that we have to look for is what the post-void residual is. These are some of the medications that can cause urinary retention. And many of these medications are commonly used in the elderly. Anticholinergic medications like antipsychotic drugs, antidepressants, opioids, anesthetics, alpha adrenergic agonists, benzodiazepines, NSAIDs, relaxants, and calcium channel blockers. So besides the medications that we mentioned, the other thing is also in men, prostate enlargement is one of the other things. In women, different types of malignancies, pelvic malignancies, can cause obstruction. So when we start seeing hydronephrosis, for example, you have to say, well, is it urinary retention that's causing this? Is there obstruction? And if it is obstruction, what's causing the obstruction? So taking the question to a complete point to completion is important. Going back to, well, how do you treat it if somebody has acute retention? The key thing is urinary catheterization, especially if acute. And then, of course, figuring out what caused the problem and then discontinuing the cause. So if it is a medication, getting rid of the medication. In the setting of anesthesia, this was something that we had looked into in the past. Looking at a preventive measure for anesthesia-related urinary retention, both during and after surgery, particularly with the use of opioids in combination with a non-opioid analgesic drug, and seeing, well, did it make a difference? The combination reduced opioid-related adverse events, but urinary retention still had contradictory results based on which study you looked at. So even the combination of an opioid and a non-opioid agent didn't really help urinary retention at the end of the surgery. Moving along, so we've spoken about some of the specific problems that the elderly face, including dosing of medications, including urinary retention, including polypharmacy, very, very superficially, just from the point of view of what's going on with the kidneys. Now moving into renal replacement therapy in the elderly. This was a slide that I found, and I am sorry to say I don't have the source of it. I think it's one of these little things that didn't come through well, but this is not my slide. This is just telling you somebody who's going through the normal aging process, somebody who's going through unsuccessful aging, as it's called, with CKD and then getting sicker. And then the point of any kind of renal replacement therapy is taking a person who's having a kidney problem, who's going through this illness, who's frail, treating them and getting them back in the cycle of normal aging. And this would be where I would see the role of any kind of renal replacement therapy. So as I'm showing you more slides and you're looking at things where the slide may not be giving you very positive information, and maybe it's talking about nursing home patients and how sick they are, that would be looking at a patient in this situation. And what we are aiming for is, with all of our therapies, to get the patient back to be better. So I have, I've treated a lot of elderly patients and some very elderly patients. This was one of the patients that I treated back in 2004 when I was at North Shore. This was a 99-and-a-half-year-old woman. When she came to me, she was 99. And she was already CKD5, very advanced kidney failure. And she had not started dialysis yet. And she had a nephrologist in Florida who placed a fistula in her. And of course, the fistula, because of her heart condition, the fistula was not maturing. And she presented in heart failure. So the first thing we had to do, I was a new nephrologist at that time. So this was a patient that belonged to our group. And we decided that the first thing to do would be to tie off the fistula, first of all. So we had to tell this 99-year-old woman that she had undergone a procedure which was useless. And we had to tie off the fistula, and then we put a catheter in her. And she was on dialysis for half a year, after which, she passed away. But that half a year was very important to her. And so she did really well for that half a year. This is case 2. This is a 68-year-old woman who was a smoker, CKD5, who was not on dialysis. Also a patient I saw at roughly about the same time in North Shore. And she decided that she was too old and she was too tired of life. She did not want to start dialysis. She basically gave her house to her grandchildren. She moves to Florida. She decides that she's going to lie on the beach. She's going to drink rum. She wanted one of the pink drinks with the umbrellas in it. And that's the way she wanted to go out. So, we respected her wishes. We had all of these different, and this was North Shore. So we had all of these different teams of people addressing what she wanted. It was a lot of social work support and different things. And finally, she actually went through the whole plan. She moved down to Florida. When she was on the beach, she had a seizure. And she did not like having that seizure. So she got on a plane, came back, started dialysis, and she basically got into a little, conflict with her grandchildren because she wanted her house back. And she realized that all of the things that we had prepared her for, while it sounded okay, in reality, she wanted to change her mind. And that was fine. She did not like the idea of having seizures. So the reason I'm picking out these 2 cases is, one, because when you put these 2 cases, roughly 2 cases that I've personally seen, taken care of, to conclusion, both of these patients passed on, but one who was much older. So when you're putting all of these people in the category, you're basically dealing with a 35-year difference between the 2 patients. One who basically thought out her entire plan. She wanted 6 months of time to get one award. And then she took herself off dialysis and passed on, the 99-and-a-half-year-old. And the second woman who basically, we thought we gave her all of this information, and she basically decided to change her mind. So 2 different variables. Okay. Moving on to mortality. What happens when you start people on dialysis? So in 2012, according to the USRDS data report, the rate of all-cause mortality is about 8 times greater for dialysis patients compared to general population. And the question is then, should we be offering dialysis to patients, to the elderly? And the fact of the matter is, we already are. The average age of the dialysis population is 62 years. And this was as far back as 20 years ago. So it's probably slightly more. What about the outcome?
Is it possible for me to ask a quick question?
I'm sorry, I can't hear what you're saying.
Yeah, a quick question. Is there a scenario in the older adult patient that is not in stage 5 kidney disease, but where dialysis is indicated?
I think there may be something wrong with the volume because I don't understand. Dr. Reinhardt, can you see if you can repeat that question? Maybe
So I was having some trouble too. Would you be able to type it out, Dr. Prosper? I'm sorry to ask you to do that. And if you need another webcam or mic, just let me know. I'll bring one over to you.
I can definitely hear what Dr. Reinhardt is saying, but I cannot hear what Dr. Prosper is saying.
Sometimes these webcams just fail, and that happens, and I have a replacement for you.
Okay.
From what I heard, it was
like he's typing. Yeah.
Okay. If there's an indication in older adult for dialysis that's not stage 5.
Is there an indication in an older adult for dialysis which is not justified?
No, not stage 5, but we can hear what he has to say.
So in terms of, we start dialysis in patients who have AKI, which, is acute kidney injury, depending on what their volume status, the electrolyte situation, whether their hemodynamics needs it, whether it's just volume removal, if there's a pericardial effusion. So there's a whole host of criteria for starting dialysis in patients who are not CKD5. In terms of progression, if you think that the patient would benefit, it's always worth exploring supporting the patient with the therapy and seeing if they would benefit from it. Many of the times when we're talking about a certain GFR cutoff, that's more for risk benefit assessment. If you're talking just about the progression of CKD to CKD5, there's no real benefit. So the early starts don't really benefit from any kind of therapy. Meaning if you instead of CKD5, if you're going to start dialysis in somebody earlier, do they benefit? Not really. Okay. So when you're talking about mortality, I want to make a specific point here also. It's the primary cause for mortality is age. And this goes all the way back from 1825 when they noticed that the chances of dying, for example, at the age of 31 was more than at the age of 30, and that's just primarily age. If you take away wars and epidemics on the side, okay? So now if you take people who are getting older and now who need dialysis, what is how do you do this? So this is actually a survey looking at how nephrologists deal with this. And from various practices, they looked at 18 different practices of nephrology practices. How do they start dialysis in patients that they think are older? So there were 4 distinct approaches. One was paternalistic, where they went ahead and made the decision for the patients. Then there was informative, where it was patient-led and they were just given information, interpretive, and then finally based on the institution. And they found 5 different themes. Now, rather than taking you through all of them, I want to go to the conclusion. The difference in the nephrologist's perception of their role, that's important, right? Like the physician is seeing a different role in terms of making a decision for patient autonomy, and successful versus unsuccessful encounters was also important to making this lifestyle change decision for patients. I think this is very important with what's out there right now in terms of what's happening with the review of what happened with COVID patients in nursing homes also. So the decision needs to be including the patients and the patient's family, providing the information, and yes, telling them what's the best case scenario, giving them all of the information, but patient autonomy as much as possible needs to be protected. Okay. What about if palliative care is involved? Now, in some situations, you're saying, okay, there's really no hope. And at this point, maybe it needs to be just palliative care. We provide dialysis therapies till a goal of care is addressed in a more permanent way. I think that's a more legal and a safer way of doing things than making the decision for the patient. Obviously, we want to respect patient autonomy and we want the family on board. So this is looking at, well, what happens if palliative care is involved? So this is in 1,300 patients who received inpatient palliative care versus usual care. And what did they find? They found that in those patients who received inpatient palliative care, they had a much higher likelihood of hospice enrollment and a much lower likelihood of rehospitalization. And I think that's important because this is really helping patients bridge that. And it goes back to those two cases that I spoke about. The much older patient who was able to decide for herself with the same, I would say with the same information. There was no real difference in the care or the information provided, but she was able to be more coherent in her decisions versus not. And this is looking at the same study. They concluded that in patients with end-stage renal disease who died in the hospital, inpatient palliative care was associated with a shorter hospitalization and lower cost. And well, this was a different study by Chen. What he was looking at is end-of-life withdrawal and palliative care utilization in patients receiving hemodialysis. So these were already hemodialysis patients who are now coming in and they're sick. What happens? This is just a single center study. And now this is talking about hemodialysis withdrawals, which is the number 3 cause of death on dialysis, is basically at some point of time, the patient and the family understands that there's no point in continuing the treatment. And the withdrawals were twice as frequent than previous when there was some sort of support. I'm going to skip this slide. Here's a question, because I think I've been talking enough. I want to see, well, kidney size declines with age, and people age differently. Men and women age differently. So who has more CKD? Is it men or women? And usually on every test, it's safer to say men age, men basically are going to have more chronic kidney disease. And this is cumulative from, multiple insults, including inflammation, vascular disease, etc. Okay. I'm going to skip this. Now, this is looking at an interesting study that we actually did right here, looking at the entire United States renal data system, which is about 300,000 patients. And what did we find out of the 300,000 patients? We actually looked to see, well, is it age that's a problem, or is it people who are actually in a nursing home, for example? And this was just a review from the data system itself. And we found that even if you look at the same age groups, people who were in institutions, so if they were in a nursing home, they did much worse if they were on dialysis than if they were the same age outside. And we made a point, this was actually a reply to one of Corella's statements, where he said, people who are older, they're in a nursing home, that's it, they're done. This was actually a reply. This was a study which was a reply to that question, which is, it's not age, it's basically people being sick. And this is the conclusion of that other point that I made earlier on, which was, as people get older, dialysis has less of an impact. Kidney disease has less of an impact on survival, because age is much more important. So for example, this is survival on dialysis between 2006 to 2010 in those between the ages of 45 to 64. And you can see based on whether they were diabetic or non-diabetic. And this is survival in patients who are 65 to 74. And you can see as time goes on, the older the person is, yes, there is a decrease in survival. But then when you look at, well, what happens to people who are in their 80s and 90s and starting dialysis? Really, there's really no difference in the 1-year survival as people get very old between dialysis or not. So what about the life expectancy for elderly on dialysis? If somebody is over the age of 65 and has a life expectancy which is lower than that of the same age without dialysis. So here's the point. I think I'm kind of struggling with making this point, but the impact of end-stage renal disease on life expectancy decreases with increasing age, and it's the smallest for the oldest age groups. Meaning if you have somebody who is 90 versus 80, the difference between actually carrying them through for a longer period of time would be less in the older age groups. I don't know if I've confused everybody by making these statements or if I've clarified things to a little bit. I think I'm going to skip this. We're kind of running out of time. And this is really showing that this is a clinical status and survival of the elderly in dialysis. And this is in one of the regions in France. And it's saying that people who keeping the same age groups roughly, you can see that the increase, there's actually been an increase in survival as time has gone on, because we are providing better care, not just in dialysis, but the rest of everything. So the cardiovascular mortality, for example, is better. You're providing better, overall the blood pressure is better controlled. So there are other factors besides renal replacement therapy. So people are living longer, even in the very elderly age groups. And this is basically the Kaplan-Meier curves for that. I think I'm running out of time. So I'm going to skip to the part where I really want to talk about the choices of renal replacement therapy. We had mentioned that transplant, even though it was very attractive, is very limited. So it's between PD and HD. Those are the two choices. And only a very, very small number of people are treated at home. So for the most part, what you're dealing with is hemodialysis. PD has really taken off last year in the setting of COVID, just because there's, the resources are more. And so I had written a paper about, avoiding PD in elderly and diabetics. And last year I came full circle because I said, well, this is an option that patients can actually do at home in the safety of their home without having to come to a center and expose themselves to a virus. And I want to take you to this slide, which is something that we did right here at Downstate. And this is looking at people who are over the age of 85 who are on dialysis. And what did we find? Well, first of all, we found that there were very few studies in patients over the age of 85. So this was one of the abstracts that we presented. And there were 11 patients over the age of 85 in our population of 290 patients. The mean age within this group was was about 89 years old. Their hemoglobins and albumins were very close or the same as patients who were not as old. They started dialysis either less than a year, or there were some patients who were on dialysis for a very, very long time. And the conclusion of that was most of our patients, even at that very older age group, came from home. They were not from nursing homes. Most of them were diabetic. They had working accesses. And here's the key thing: they had normal cardiac function. That was the most important thing that we saw. And our conclusion was age alone obviously should not prevent anybody from starting dialysis, even in the very elderly, even over the age of 85. Okay. And so this was a study that I had basically said that I kind of came full circle to. What is new in 2020, 2021? And there were a few studies that we actually published where when we looked at our COVID patients, the people who came down with AKI, the risk factor was age. And it was the same thing when we looked through all of the various things. The key risk factor was age. And I think that's really obviously connected to prior pre-existing comorbidities that they have. This is just the final slide that I'm going to leave you guys with, which is if a person needs dialysis, I would really put the patient first rather than just going with what the literature says. When you're dealing with a very older patient, you're saying that you're going to put in a fistula in somebody who may never benefit from it. And I go back to my 99-year-old patient and I say, well, if that patient actually went into heart failure because somebody put a fistula in them. So it depends on what their cardiac function is. Can their cardiac function support the surgery and the fistula? And will they actually benefit from having the surgery? So I would not put a fistula too early. I would wait, for maybe 6 months before they actually needed it to put it in, rather than putting it in years ahead of time. With that, I'm going to stop. If there are any questions.